السلام عليكم ورحمة الله تعالى وبركاته. أسمحوا لي قبل أن نبدأ هذا السيمينار أن أترحم على جميع شهداء الواجب في مجال الحقل الصحي أينما كانوا خلال وباء فيروس الكورونا المستجد، وأخص بالذكر مستر عادل الطيار، مستر أمجد الحوراني، والزميل حافظ جلال، لهم جميعا الرحمة والمغفرة بإذنه تعالى. مرحب بالجميع. أنا سارة إبراهيم حسن عبد الجليل، استشارية أطفال بالمملكة المتحدة. برحب بالجميع في أول ويبينار فيما يختص Fighting COVID-19. فهنتقل now for the slide. Our theme for today, Sudanese doctors abroad stand united supporting colleagues and health professionals in Sudan in our fight against corona pandemic. This is a collective work which is organized by the following groups: Sudan Doctors Union UK, Sudan Doctors Union in Ireland, Sudan Doctors Union Canada, Sudanese Australian Medical Professionals Association, Sudanese Doctors Association in Qatar, Sudanese American Physician Association. We are honored to have very distinguished speakers who are Dr. Magda MA Ali, Dr. AbuObida Hamor, Dr. Husam Osman, Dr. Ibrahim Fawzi, Dr. Suhail Gamal. As well, we are very grateful to ASEIT, which is a group of Sudanese engineers and ICT professionals decided to gather together and work on a voluntary project that benefits the members and the wider Sudanese community in Ireland, who are providing the technical support today. Just a few housekeeping points. We have 4 presentations. They will be delivered. In the meantime, if you have any question, please type it in the chat box. You write your name, where are you based, who would you like the message to be addressed to. The Q&A session will start after the four presentations. The moderators will read out each message and will try our best to read out all questions if possible. It depends on time, obviously. During the webinar, your microphone will be muted, as well as the video button, and that reduces the interruption in view of the potential internet challenges. This is the first tester for us as a group, and so please accept our apology in advance, and any difficulties, please bear with us. Before we start, I would like to introduce our moderators today: Dr. Shaza Taha, Family Medicine, Academic Office, SDU-UK; Dr. Mohammed Jamal, Chest Physician, Media Office, SDU-UK. And now I will move swiftly to introduce the first speaker, if that's possible. So we are very grateful for Dr. Magda MA Ali, who will speak about global health challenges and COVID-19 pandemic. Dr. Magda Ali is well known to the majority of us. For those few who don't know Dr. Magda, she is a founding member of Al-Manar Women NGO, which was established in 1991, and Secretary of POD. Dr. Magda is a community physician, and she was the director of the National CBD program in the Ministry of Health during 1984-1989. She has been a consultant and facilitator to several NGOs and co-founder to a number of civil societies and organizations. She has submitted several conference papers and studies on many public health issues. اتفضل يا دكتورة ماجدة.
السلام عليكم. Slide 1, please, slide 1. The SARS novel coronavirus was first detected in China in late 2019. Its subsequent exponential spread and the declaration of the COVID-19 pandemic has resulted in high mortality rates, overwhelming health systems, weakening economies, and initiating geopolitical change. Even before the pandemic, there were huge challenges facing the world: climate change, political instability, local conflicts, escalating humanitarian emergencies, pollution, epidemics and infectious disease, misuse of resources in relation to health, and soaring food prices. However, these interrelated issues that have a devastating effect on health and well-being were not addressed. Consequently, the health systems faced shifting demographic trends, changing food habits, increasing expenditure on unhealthy products, leading to epidemiological shifts towards chronic non-communicable disease. This move focused production of innovative medicines and health technologies that were highly priced, challenging the sustainability of health systems. The health sector became a money-spinning sector with considerable return on investment, accounting for nearly 20% of the GDP in developed and industrial countries. As a result, there was a gradual shift towards curative health care, with dwindling public health institutions delivering basic health care and public health activities. Unfortunately, the very public health sector institutions that are set to overcome the very crisis that the world is facing now were eroded. Next. Global healthcare delivery systems are being developed in a way that is bringing about both helpful advances and ethical challenges. Inequality in terms of both healthcare access and utilization continues to be a global concern. The challenge of fulfilling health as a human right, defined as, next please, the enjoyment of the highest attainable standard of health, is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic or social condition. This definition needs to be endorsed in the face of future disasters to which the world is prone, given the fragility of globalized economies. To address future disasters, the main focus should be on health and food security and socio-economic conditions that can relieve financial debt. Hence, a suggested approach for health, economic and financial responses informed by the Sustainable Development Goals could be the following. First, understand that this great global crisis is unprecedented, and we must continue to sustain the support to the health sector after the crisis by reviving primary health care and universal health coverage to fulfill SDG 3. Invest in education, knowledge, and human capital in the age of digitalization to ensure quality education as outlined in SDG 4. Focus economic stimulus on the most vulnerable people and businesses to eliminate poverty and reduce inequality. Prioritize economic policies in full partnership with a whole nation approach, with clear determination of the roles of government, community, and private sector to ensure that we are addressing the social determinants of health. Localize development and investment, and finally, accelerate digitalization. Thank you very much.
Thank you very much, Dr. Magda, for the precise speech. And it is, yes, the pandemic has exposed a lot of gaps, and we need to endorse health as a human right. For anybody who has or not followed Dr. Magda, the script of her presentation will be published on our website, sdu.org.uk. Now I will move to the second speaker, Dr. AbuObida Hamor, Clinical Characteristics of COVID-19. Dr. Hamor is a consultant physician and a clinical associate professor in University Hospital of Northern Columbia, Northern Health Medical Lead for HIV, HCV, antimicrobial stewardship and infection control programs, internal medicine, infectious disease, tropical and international medicine, certificate in travel health. Dr. AbuObida as well is representing Sudan Doctors Union Canada. اتفضل يا دكتور AbuObida. دكتور AbuObida.
Hello, can you hear me?
Yes.
Assalamu alaikum. Thank you very much for the kind introduction and the invitation to participate in this webinar. I've been tasked with the task of presenting on clinical characteristics of COVID-19. If I could have the first slide, please. Could I have the first slide, please? Next. I would like to start by presenting a case that we recently had at our hospital of a 49-year-old gentleman whose wife attended a conference in Vancouver the week before presentation. He basically presented with a short history of fever, dry cough, and fatigue. When he was seen in ER, he was pyrexial, but his other vital signs were stable. His white cell count was on the low side. He was lymphopenic. CRP was elevated. The platelet count was low. And his chest X-ray showed faint bilateral lower basal infiltrates. A nasopharyngeal swab was collected and sent for COVID-19, influenza A, B, and RSV. As he was clinically stable, he was given a single dose of IV ceftriaxone and sent home on azithromycin, hydroxychloroquine, and oseltamivir. He was advised to return if he became more breathless or sicker. Next slide, please. He did return 2 days later with worsening dyspnea, and at that time, his COVID-19 swab came back positive. He was put in an isolation room. He was barely maintaining his oxygen saturation on 10 liters of oxygen. So he was hypoxemic and had to be transferred to ICU for further management of hypoxic or hypoxemic respiratory failure. He was intubated and ventilated. At the time, his labs showed a normal white cell count. His platelet count was still low. His CRP was over 100, and his LDH was twice the upper limit of normal. The chest X-ray showed worsening of the patchy infiltrates. If I could have the next slide to show that, please. As you can see, the X-ray showed bilateral, basal, and peripheral infiltrates. Next slide, please. So he was intubated for about 10 to 11 days. During his stay in the ICU, the WBC count gradually recovered and improved, and so did the lymphocyte fraction. Next slide, please. Next slide, please. The platelets were initially low, but gradually recovered and then even rebounded. This was one of the manifestations of inflammatory response that we expect, platelet increase or thrombocytosis after an initial period of thrombocytopenia. Next slide, please. The D-dimer was initially elevated, and this also subsequently came down to normal level. Next slide, please. The ferritin, which is a well-recognized acute phase reactant, was initially elevated and subsequently came down. And this is one of the features of the so-called cytokine storm that is often seen in these patients, with marked elevation of ferritin, CRP, and D-dimer. This patient is now on the ward. He's requiring minimal amounts of oxygen and is ready to be discharged home in a day or two. Next slide, please. So now I'll just go over the clinical features of COVID-19 as documented in the literature. The incubation period of COVID-19 ranges between 2 to 7 days, with a median of 4 days, but it can be up to 14 days. Next slide, please. These are the symptoms as documented in a study from Wuhan, China. Over 1,000 cases were reported in the New England Journal of Medicine at the end of February, and the paper showed that the main presenting features of this disease are fever and a dry cough. But it's important to note that in the Chinese experience, over 50% of patients did not have a fever at presentation. Subsequently, during that admission, up to 90% of patients had a fever. But initially, fever was absent, and this is important to remember so that we do not, it does not put us off the diagnosis, or it doesn't rule out the diagnosis of COVID if the fever is absent. About a third of patients may have a productive cough, but the majority, or 2/3, have a dry cough. Fatigue is a non-specific symptom that may be present in various viral illnesses, so it's not specific to COVID. Breathlessness is a late feature and should always be taken seriously, because patients who are dyspneic or breathless need to be assessed for admission, as they may have pneumonia or ARDS. Diarrhea is a rare symptom and may be present in less than 5% of patients. Next slide, please. Other less common symptoms that have been reported from Italy in particular are the loss of the sense of smell and taste. This tends to occur, or according to the Italian data, it was noted in about 1/3 of patients have a loss of sense of smell or taste, and both in about 20% of patients. Other symptoms that may be seen in this syndrome are obviously headaches, and sore throat, and rhinorrhea, and these are very non-specific and can occur with any other viral. Next slide, please. Radiological findings are seen in on a chest X-ray. Abnormality is expected in about 60% of patients, but the CT may show abnormalities in over 80% of patients, even in asymptomatic individuals. There is a study that showed that asymptomatic patients who contract COVID, 50% of them may show CT abnormalities. The typical abnormality seen on CT is ground glass appearance, and the CT can be normal in up to 18% of patients who have non-severe pneumonia, and in about 3% of patients who have severe pneumonia. So even the CT can be normal. Next slide, please. I think I'll skip the slide in the interest of time because it just describes what I said. Next slide, please. This is an example of chest X-ray progression showing increasing or worsening infiltrate that usually start basally and peripherally, and then they move to the center. And you can see these. This is the initial X-ray in a Wuhan patient that progressed to more widespread shadowing within 3 days of the first film. Next slide, please. This is a typical ground glass shadowing or infiltrates that are seen in COVID, but again, these are not specific and may be seen in other viral pneumonias or other pulmonary conditions. Next slide, please. This is a 3-volume reconstruction, again showing the patchy infiltrates after progression to involve the central parts of the lung. Next slide, please. There are some uncommon radiological features that that we would not expect to see in COVID patients, and these include pleural effusions that are seen in only about 5% of cases, masses, cavitation, lymphadenopathy. These are unlikely to be present in COVID patients, and if they are, they should make us suspect an alternative diagnosis. Next slide, please. The typical or cardinal laboratory features of COVID-19 is lymphopenia or lymphocytopenia, which is present in over 80% of cases, followed by leukopenia in about 1/3, and likewise thrombocytopenia in about 1/3 of patients. And as we've seen in the patient that I presented earlier, CRP elevation, ferritin, D-dimer elevation, these are frequent findings representing the acute phase response or the inflammatory reaction. Next slide, please. So the WHO classifies the syndrome into various subtypes or syndromes. The commonest is going to be a mild illness, uncomplicated upper respiratory tract infection with no signs of respiratory distress, sepsis, or dehydration. And within this category, there may be some patients, or another category maybe before this one could be the asymptomatic people. And in a study from one of the cruise ships, it showed that about 20% of people who tested positive for COVID were actually asymptomatic. So maybe 1 in 5 people will have no symptoms at all. And then you have mild pneumonia and severe pneumonia with tachypnea and oxygen desaturation or hypoxemia, confusion, systolic or diastolic hypotension, ARDS, and some patients may obviously present with sepsis or severe sepsis with septic shock. Next slide, please. So this is my last slide. Just to illustrate the factors associated with a poor outcome or increased mortality in COVID patients, and these are advancing age. The older patients, the higher the risk of mortality. In the U.S. Data, we know that over 80% of those who died are above the age of 65. And in Chinese data, the mortality among those above the age of 80 was about 20%. Presence of comorbidities, whether they're cardiac or pulmonary or other diabetes or cancer, that adds to the more comorbidities, the higher the mortality. And then the elevated markers that we saw in our patients, like D-dimer, CRP, the troponin elevation indicates myocarditis or myocardial dysfunction, and likewise CK and LDH. Lymphocytopenia is also a prognostic feature, and so is elevation of the prothrombin time and presence of acute kidney injury or secondary infection. So this is just a brief overview of the clinical manifestations or characteristics that we might see in patients with COVID, as illustrated by the case that I presented at the beginning of this presentation. And with that, I thank you very much. Next slide, please. Thank you very much for your attention.
Thank you, Dr. AbuObida, for the thorough lot of discussion about the clinical presentation. And we may come back later with some questions about sort of the new protocols and the role of some new sort of medication that people have been debating. Thank you very much. I will now swiftly move to introduce Dr. Husam Osman. We are very grateful for Dr. Husam to join us today to talk about public health aspect and diagnostic challenges of COVID-19. Dr. Husam is a consultant virologist and clinical service director in Birmingham Public Health Laboratory and Birmingham Heart Hospital. Welcome, Husam. تفضل.
شكرا جزيلا. Thank you very much for the invitation. I'll just take the opportunity with my presentation to talk today about the public health issues related to COVID-19. And at the same time, talk about England as an example. Okay, this is very slide. This is just give you a timeline about the story with COVID since it was first described in the 31st of December last year, and when were the first cases reported and so on. And going down till present day or yesterday, and this is the, as you can see at the end, the last count of numbers in the United Kingdom up to yesterday. The slides will be available for people if they want to go in details about this, and so just for the interest of time, I will move on now. So this once since the epidemic began, and this is the story in China. As you can see, the numbers since the beginning of the epidemic till now is slowing down significantly in China, and ending at about 80,000 cases in China. Next slide, please. So lots of studies came out after the experience in China, and they compared COVID-19 to the coronavirus, which cause mainly severe pneumonia and so on. So you can see as what they looked at is the productive number and the doubling time, the incubation period, and the mortality and so on. And if you can look at this table, the reproductive number, just for people, excuse me, I know you all know this thing, just explain. The reproductive number is the number of people infected by each single case. As you can see, COVID is just like SARS, but more than MERS and influenza. The doubling time is how much the number double each, takes double the numbers each and each time point. And as you can see, the COVID also takes a very short time compared to MERS and SARS. And then Dr. Hamor spoke about the incubation period. And then we talk about the mortality, which is a big difference. That although the virus have got very infectious because of the reproductive number and doubling time, but the mortality compared to SARS and MERS is very low. SARS is 9.5, for example, MERS up to 34%, and the influenza is less than, but COVID is only about, as you can see, up to 4%, although the numbers are changing all the time. Next slide, please. This slide just shows you the difference or the effect of different viruses and the reproductive number with the mortalities and this and so on. If you can see, COVID is in the purple color there, is more than influenza, for example. Even the pandemic influenza in 57 and 2009, and that's why it has got a higher mortality than those two viruses. While, for example, if you take chickenpox, which is a very contagious disease, has a very high reproductive number, but the mortality is low, while measles on the top corner, on the right top corner, right corner, and smallpox have very high mortality and a very high reproductive number. Next slide, please. This is the picture here in the United Kingdom. As you can see, the number of cases in the green line, the green line, it shows you the curve of the epidemic since the beginning of the epidemic here in February and so on. And the one red line is the mortality associated with the cases so far. And for example, these are the numbers yesterday, in the morning of the 10th, which has 70,000, with 8,000 deaths. Today, for example, now, the mortality is the cases have jumped up to 79,000 cases, as the mortality is nearly 10,000, is 9,700, 800 cases. So it is a big problem now, and we are having big issues with this epidemic here in England. The numbers are going on double every day, and it's putting a lot of pressure on resources and so on. Next slide, please. This is just to compare what's happening here in the United Kingdom with France and Italy and Spain, who are also hit very hard with this epidemic. As you can see, we have going in the same trajectory as Italy, Spain, and Germany, and France, and so on. While countries like South Korea are starting to smooth out the effect of the pandemic and so on. Next slide, please. So, with this sort of epidemics or pandemic, you have to take measures to try to limit the impact of the pandemic on the services and on the community. So the red, for example, curve is if you do nothing, you haven't done anything, that will happen. The curve will go up and up and up, and then it will come down, but it will take a time, and the casualties will be very high. So the idea is to get to the blue curve, which is what we say flattening the curve, to introduce some measures to reduce the impact and to flatten the curve so your healthcare systems can cope with what is going on. Next slide, please. So there are two public health policies people can use to fight the pandemic. The first one is to contain the virus, and that by what they mean is identifying cases, isolating them, and then identifying the contact of the cases, testing them, and manage them accordingly. It's less effective in flattening the curve, and then it may have a possible repercussion in the short term because of the limited health capacity, but it will help that people get infected, of course, to build immunity, and may help in the long term. The other policy, of course, is to try to suppress the virus or lowering the replication number of the virus, and which is what we call lockdown, so people don't go out and so on. And it will help in definitely in flattening the curve, but the other problem is that the population will still become vulnerable because people are not exposed to the virus. So you may have a second wave after that, even if you manage to flatten the curve. Next slide, please. So these are views of Professor Sorico and Professor Galitoli here in the economic from the School of Business here, and they were saying whatever you do, the price is very high. So if you can't find a vaccine very early on to the virus or to whatever the microbe is, and which is the case with COVID, I don't think you will have a vaccine very early on. Still, you will have so many casualties, whatever the policy used, either containment or suppression. There will always be a very high price to pay, and that's what is currently seeing now in the United Kingdom. Next slide, please. This is an example from the big pandemic influenza pandemic in 1918, and the response of two cities in the United States of America to the pandemic. The first city was Philadelphia. The first case was reported on 17th of September, but they didn't take much care of it. They went on with a very big citywide parade in the 28th of September, and as you can see, the curve, which is black line, very high casualties, and a lot of people died and suffered. While in another city, which is St. Louis, the first case was on the 5th of October, and then just 2 days later, they immediately introduced measures to contain the pandemic. And you can see in the dotted line, the effect of that was very successful in containing the pandemic at that time. Next slide, please. This is, again, another example of the response of two countries to the pandemic. One of them is South Korea, as you can see in the green line down there, and Italy. So South Korea was very aggressive in fighting the pandemic. They introduced social isolation, they introduced rapid scaling of testing and isolation of patients and so on. And you can see they managed successfully to control the pandemic. They had only about 8,000 cases in the country. With very little mortality compared to Italy, which is still suffering from what's going on with the pandemic. Next slide, please. This slide just shows you what we did here in England. Since the 5th of March, we closed with a notifiable disease. Then we introduced measures gradually to close the schools and so on. And the 20th of March, that's when we finished England started introducing the lockdown. And at that time, on the 5th of March, the 20th of March, sorry, we have about 5,000 cases and only 233 deaths at that time on the 20th of March. Next slide, please. This slide just shows you the case fatality rate and the cases per 100,000 in different European countries. As you can see, Spain in the lead there with very high numbers per 100,000 and also high mortality rate, and Italy, and Belgium, and so on. United Kingdom in the red there, we are still have very high mortality compared to, although the numbers are not as excessive as Spain and Italy, but we have a high mortality there compared to them. While you take countries like Germany, I just want you to notice that Germany there is very high, although they have more cases than England, but the mortality is very, very low. It's 2.8%, 2.8 per 100,000 cases compared to England, which is about 13 cases per 100,000 cases. Next slide, please. So, why is England still suffering or having big problems? This slide there shows you when the lockdown was introduced in different countries around the world. And as you can see, that some of the countries there introduced the lockdown very early on, although they didn't have the same number of cases like the United Kingdom. And the United Kingdom only introduced that, as I said, on the 20th of March, which is the number 4 on the table there, only on the 20th of March. So it was, I think, some people say very late, and they delayed it, and maybe that's why they have problems, still having problems with the epidemic. Again, with the lockdown, of course, one of the other issues which you need to introduce to fight them is to have vast amount of testing, large amount of testing to pick up people and isolate them, admit them to hospital, and so on. But the United Kingdom have problems with testing. Next slide, please. The problem we had here is that we have a shortage of diagnostic tests because this pandemic hit most of the countries of the world and most of the developed countries of the world. So they were all, they don't have a problem with paying for these tests. So the demand was very high, and so there was a big shortage because all the countries wanted the same material for the testing. The other problem we had in the United Kingdom, of course, here we don't have a diagnostic manufacturing industry in the United. So all the big companies, diagnostic companies like the Roche, the Abbott, the Qatar, they're all based outside the United Kingdom. And we know that now, for example, the United States have some sort of an embargo, anything diagnostic to leave out the United States because they wanted it themselves. Again, there was a questionable quality of some of the tests which came through, and they were not very good, so we couldn't use them. We didn't have a very good, reliable serologic test to look for IgG or IgM. Some tests on the market, but they are not very good. Then we have a problem with logistic of having test facilities, how we store and transport diagnostic material, reporting of results, and so on. So we have a big issue because suddenly we are faced with this big demand, and I think United Kingdom were not ready. Next slide, please. This is just to show you the projection of the test, the molecular tests that need to be till the end of April. The black line is what need to be done daily, about 30,000 tests per day, and we are still very early on. We are doing about 16 or 15,000 tests so far, but this is what the projection and what is supposed to happen by the end of the month. Whether we will be able to do that or not is still questionable. Next slide, please. So the plan now is the plan is to have these 5 pillars. The first pillar is to increase the number of molecular testing. As I said, the projection is to get to about 30,000, and introduce also commercial PCRs and so on, so you can increase the amount of testing in the community. And the third pillar is to have a good antibody testing as a diagnostic test. And then pillar 4 is to have a very big also serological platforms to do large serosurveillance studies in the community. And then the fifth pillar is to actually not to be faced with the same problem again, to have a big diagnostic national industry in the country, which of course is going to take time. So they are working now within all these pillars, different categories of the public health and NHS are working on these pillars, but there are still live problems and big problems facing them. Next slide, please. So this is my last slide, and just to show you that this virus is very transmissible. It affects average patient affects about up to 2.4 people. It mainly, as Dr. Hamor said, it infects the elderly. Fatality is mainly seen about the elderly. The under 40 seems less than 2.2%, and the other men are also, as Dr. Hamor mentioned, are highly infected compared to women. And there is a lot of unknowns. We know that, for example, asymptomatic people are a source of infection, but we don't know how the magnitude of that and what part they play on the pandemic. We don't know, for example, yet if you recover from the infection, are you going to become immune or not? And we don't know whether this virus is going to be seasonal, for example, just like all other respiratory viruses, which will come only in winter, it's going to be all year round. So these are all unknowns about this virus. But the immediate thing, of course, is to overcome the current problem and then get to the next stage. Thank you very much.
Thank you, Husam, for this presentation, which ended exactly that we are uncertain about the virus. It's hitting the health service significantly, globally, and I think it highlights that the issue with health is not just a national, it's something that has to be looked at between all different countries away from politics. So thank you very much. I think we may come back with some questions later. I would like to introduce the last presentation, which is going to be delivered by two colleagues, Dr. Ibrahim Fawzi, the ex-chair of critical care, ECMO, lead and consultant intensivist in Hamad General Hospital in Qatar, and my colleague Suhail Gamal, who is a consultant anesthetist and intensivist in Hamad Hospital in Qatar. اتفضلوا.
Okay, thank you, Sarah, and thanks for the introduction. First of all, I would like to say كل عام والشعب السوداني والثورة السودانية بألف خير. At these difficult times where we were hoping that everybody is going to be breathing the breeze of freedom, unfortunately it coincides with this pandemic, which humanity hasn't seen for a while and made us all breathe heavily, but hopefully many returns, and in which the country and the people of Sudan are breathing the breath of freedom and liberty once more. So my part of the talk is going to be quite brief. So I'll be mainly setting the stage for my colleague Dr. Ibrahim about when it comes to our critical care preparedness for COVID-19 pandemic, and hopefully he will get the tough questions from you guys. So first slide, please. Okay, so we all know the numbers, yeah? So every day you turn on your TV, you see these numbers popping up on your screen. The cases confirmed are going up. The cases recovering are also going up, not at the rate that we would like to see, but at least it is going up. And the number of deaths, unfortunately, is going up as well. These numbers, I think, were from this morning. Johns Hopkins seems to be the center now, which everyone is referring to get the numbers. I'm sure these numbers are up a couple of thousands since the last time I checked. And as you can see in the map above, the disease is not really uniformly spread. You can see that there's hot spots there. Now shifting from mainland China to Europe and UK, Spain and Italy being quite hot at the moment, and also moving across the Atlantic to where New York seems to picking up. But we can see a relative spareness or scarcity in Africa, especially sub-Saharan Africa, which is making people postulate different theories and what's the cause behind it, and which probably we're going to deal with in our discussion. Next slide, please. So I tried to look for numbers of ICU admission, and there is nothing really established there. We know it goes up as the death mortality are going up as well. These were the numbers I could get from Dave Manca in Italy, and he was looking at the ICU patients, the number growing in his ICU in Lombardy, and you can see it's almost a linear and an exponential growth, as you can see in the case on the right on Italy. And the scary bit is that what we call the lower inflection point, that's the point where the graph really takes off, okay, can happen at quite a low number. So if you see there, you can see that after 10 days, probably the number was around 200, but in 5 days after that, it doubled to 500, and then it goes up, and it goes up quite exponentially, which is quite scary. Now, this of course depends, and the limiting factor for it is how many ICU beds you have in that region, because a lot of patients in countries where there's no abundance of ICU beds are not included in, will not be included in graphs like these, and unfortunately might pass away unrecognized by our figures. Next slide, please. So, as the two previous speakers have pointed out, you can see that the majority of patients who will have COVID-19 will have mild to moderate symptoms, and actually the best way to combat that is isolation and social distancing. However, a portion of them will have some kind of severe, moderately to severe symptoms, and would necessitate them to go to the hospital and get a bit of oxygen therapy. The minority, which is usually quoted around 5% of patients will develop critical symptoms and might need critical care. Now, the problem is when you look at the resources required to deal with this, it's the opposite way. So those who are critically ill and will go to require mechanical ventilation and ICU therapy will need a hell of resources, whether it being manpower, being it equipment, being it medications, and etc. So, and that's one of the big problems when it comes dealing with COVID-19 and again, not being able really to flatten the curve, that you will need a lot of resources, and it's for a small population. Next, please. So another problem which shows itself is how we manage this pandemic and medical management, I mean. And there is a lot of societies out there who published a lot of consistent statements, like, you know, the Surviving Sepsis campaign, for example, or the Australians, the ANZICS in New Zealand and Australia, or the European Society, a lot of societies which published different recommendations. But probably the one most of the world would go with is the World Health Organization. And I would like to point out to pretty much the first two lines you read when you read this document, and which says that this publication is adopted from the clinical management of severe acute respiratory infection in MERS. Okay, so we don't, and the reason for that, I mean, we don't know a lot about the COVID. We don't have a lot of randomized controlled trial, as you would imagine, in this short time. And there are some of the research that's coming with very, very small numbers. So you have, you know, studies which have 80 patients and stuff like that, which usually would never have seen its way through a peer journal, but now it's making all its way to JAMA and all top-ranked journals. So that's the problem. We're extrapolating what we know from the SARS and from MERS to COVID, which is not necessarily true. Next slide, please. Next slide. Yeah, so when it comes to how can we be prepared in ICU, I mean, this is a list which was prepared by the Society of Critical Medicine in the US, which mainly covers 7 areas: preparedness, logistics, communication, triaging, protection of staff, and essential equipment. Now, each one of those, I would imagine, is a talk on itself, and how much and how far can you go with each one and what are the limitations is quite a big talk. And I'll leave it here. Actually, this is my last slide, because I'm going to pass the heat on to my colleague and friend Ibrahim. Hopefully he'll have some answers in his presentation. Ibrahim. Ibrahim.
See, I'm mute or mute?
Can you hear me now? Sorry for that. Can you hear me? Assalamu alaikum, everybody. It's a pleasure to be part of this fantastic group. As you know, my name is Ibrahim Fawzi. I'm Director of Critical Care at Hamad and ECMO Program Director. And I have the luxury to be trained partly between the US, most of my training at Cornell and at London and Guy's and Plymouth. So I will follow on of what Dr. Suhail actually talked, and I will try to really cover basic aspects and general aspects as well. And I start with the next slide, please. Can I have next slide, please? This is the way to do quarantine. No, you go back, please, to the Arabic version. If you can go back. So إذا سمعتم به بأرض فلا تدخلوا عليه وإذا وقع بأرض وأنتم بها فلا تخرجوا منها فرارا منه والمقيم بها كالشهيد. صدق رسول الله صلى الله عليه وسلم. So this is the start, and I think this is the basics of how to do quarantine. We have to really follow the instruction. If we go to the objective of my talk, which is next slide, please. what I will be covering is some general principles, so to give you a bit of facts about COVID. And then I will focus in critical care aspect, and we'll touch about equipment, manpower utilization, and how should we plan for Sudan, for instance. Next slide, please. So, in general principle, we need to know certain rules. Number one, it's actually a new virus. It's not the regular coronavirus that we used to deal with, whether it's MERS or SARS. It's a bit different. It's actually a mix of both. It's evolving science. Every day we are learning something new about this virus and how it affects the human and how does the body respond to it. So every day we will have new data. And I see a lot of questions, anticoagulation, chloroquine and other drugs. We will try to cover part of that, but every day we learn something new. It's very contagious, and our colleagues already spoke about that. 1 to 2.6, 3.2 ratio of people that get infected. And it's also very complex pathophysiological effect, which I'm going to talk about it. And people hear about the fatality rate. Case fatality rate is very undermining of this virus, because this virus is so contagious, and 80% of the patients who receive it are usually asymptomatic or mild symptoms. But the ICU mortality of this COVID virus is actually as high as the MERS coronavirus, 50% mortality. It can range from 20 to 50% mortality, which is very, very high. Can we go to the next slide, please? So, as I said, every day new publication regarding pathophysiology and treatment aspect. Next slide, please, which I'm going to go quickly. I already explained about the next one, which is it's overwhelmed top healthcare system in the world. We have example of the United States, Italy, and other. And it's very important to spend your resources to contain this virus rather than face the herd immunity and to face the massive casualty, because this is it's a suicide for the country. Going to the next slide, which is a very high ICU mortality. If you go to the next slide, so in this slide, there's two data, one from the UK and one from China. And I put the UK because you can see 50% ICU mortality. This is mean if two patients comes, one of them die in the intensive care. And UK is very selective, so they don't admit everybody to their ICU. This number is exactly the same in Italy. It's exactly the same in China. It's very high. This is very scary. That's what the problem with this COVID virus is. Not just it's because of fatality rate is low, but if you end up in the intensive care, you have a 50% mortality risk. This is very scary. If you go to the next slide, you will see the age group, and this is also published by the ICNAR. Can you go to the next slide, please? Next slide, please. Okay, so here you can see age 16 to 49. These are young people, 23% mortality. 4 admitted, 1 died. This is very, very high. This is comparing to 10% for different virus pneumonias. So it's not only the rumor that this is only for elderly, it actually kills young people who are healthy as well. So we have to be careful with this disease, because if you end up in the intensive care, the likelihood of death is anything between 23 and 50%. Next slide, please. Next slide, please. Okay, staff safety is one of the big founders for this COVID virus. Hundreds of Italian doctors and other nurses, healthcare providers got infected, and a lot of them died actually, which also add another burden. So when we prepare anything to face this pandemic and epidemic in a country, you have to really take care of your soldiers. These are frontliners. So when you plan, you need to plan it as such that you can protect your fighters. Otherwise, you'll end up with equipment on ICU and no one to operate them. So this is an important fact. So let's move to the next slide, 2 slides quickly, which I'm going to talk about critical care aspect. If you can move to the next one as well, a bit of pathophysiology. So this virus, when it comes in, it binds to a receptor called ACE2, angiotensin converting enzyme 2. Receptor, and with that it enters the cell, it replicates, and it form another virus. So we use the respiratory cell, the lung cell, to be their factories. And the concept of ACE is important because everybody asks about angiotensin converting enzyme. Most of the data actually doesn't support that using these drugs can affect the virus in a bad way. It's actually as a protective. But this is the way the virus uses the cells and replicate and then cause the disease. So if you move to the next slide, please. Most of the treatment is working toward inhibition of this replication, whether it's anti-malaria with HIV and other protease inhibitors. It works to inhibit this. So if you go to the next slide, it will give you, for instance, the effect of hydroxychloroquine, which is inhibit the pH in the lysosome, so it inhibits the virus replication and release inside the cell. There is another drug, ivermectin, that's coming up. It also inhibits the passes of part of the virus to the nucleus. And most of the drugs work on this phase, is to inhibit the virus replication. When you go to the next slide, please. Next slide. So the next slide show you effect on the lung, because most of the tropic of this virus to the respiratory system, although it can go to the GI, and that's why some of the patients will present with diarrhea, because they also carry the ACE2 receptor. As I said, most patients go to the right side, which is the mild infection, majority, but some patients will progress to acute respiratory distress syndrome, which is a severe inflammation in the lung. But not only that, it's not just the inflammation in the lung. It has a different mechanism than most of the other viruses, because it affects the vascular permeability. It affects the producing pulmonary capillary microthrombi, the BQ mismatch. So it's not just one mechanism of hypoxemia, which I'll explain in the next few slides as well. So if you go to the next slide, it will show you a different also mechanism. If you go to the next slide, it also affects the hemoglobin, the beta chain, and the affinity to the hemoglobin. And this is in its own can carry a lot of problem. It also increase the risk of hypercoagulable state and can produce patient to microthrombi, but also pulmonary embolism as well. So there is so many mechanisms. This is completely different than MERS corona. We treated MERS corona. Some of them have high mortality, but this is a bit different disease. It's not just a respiratory. It gives you more than just respiratory. If you go to the next slide, it will show you the different subtypes in the lung. So the type in the right, which is the phenotype H, you can see the CT scan. This is two different patients with COVID. One, both of them have a low PF ratio, PaO2 to FiO2 ratio. One with a consolidated lung, the one on the right, phenotype H. This is what we usually see. We see this in MERS, we see this in H1N1, we see this in bacterial pneumonia, and we know how to treat this very well, actually. Low type protective lung ventilation, and so on. The algorithm is pretty clear. But the phenotype L, that is a different emerging thing. It doesn't have a lot of lung findings, but it affects mostly the microthrombi, the hemoglobin, affect the BQ mismatch, and so on. And these type of patients, if you give them high pressure, you can actually cause a lot of death among these patients. So they have to be treated carefully, and you have to identify these patients. So if you go to the next slide, which was adapted from my friend Luigi, and obviously Professor Gattinoni, looking at the management of these patients when they get intubated, you have to assess the lung compliance and differentiate these two types, whether it's a L type or H type, and you put your strategy. But if you look to both, something called prone responsiveness, prone position ventilation, is something that is, it doesn't require any budget. You just train your people to do prone position, which means the person sleeps and his abdomen will freeing the abdomen, and that improves the lung mechanics significantly. And I think this is, if you have a resource limited, that's where you need to really train your team to do prone position ventilation. You can do it even before intubation. Next slide is important because it's, if you go to the next slide. Can we go to the next slide, please? So this slide shows you stages, because it's not only lung that get affected. Stage 1 is early infection. Stage 2 is a pulmonary phase where you get all the findings that I said, that I described earlier. But stage 3, some of the patient will progress to host inflammatory response phase. which we call cytokine storm syndrome. And these patients, actually, majority of them end up with vascular collapse, with myocardial depression, cardiogenic shock, and a lot of them die from stage 3. Even if you fix everything in the lung, some of the patient will progress to this disease. So you really need to know where are you in the phase of management of this patient to tailor your therapy according to the stage. So if you go to the next slide, the next slide will tell you therapeutic options. Therapeutic options are really targeting 3 areas: viral replication inhibitors, which is chloroquine, hydrochloroquine, and all these drugs. Remember that all these drugs is it's a disparate measure, really, because we don't have a randomized clinical trial, but now we don't have time for that. So, you know, there is no time to prove it. So there is all depend on a very small study. But you know what? That's what we have. So we cannot. We have to balance the risk of this drug versus the benefit. The second group is a pulmonary support. Is a patient who, especially in a phenotype L, that require some VQ matching, which is nitric oxide, prostacyclin, some anticoagulation, and corticosteroid can help in certain group of patients. Group 3, it works mostly in the cytokine storm syndrome, which is tocilizumab, interleukin-6 inhibitors, derivative IL-1 inhibitors, and corticosteroids. So those are sort of the option, and I think the science is still evolving, and we're learning every day something, and the list will increase. So moving to the next slide, please. It tell you, okay, so now you have all this disease with a different physiology. Everybody talk about ventilation, ventilator. Ventilator is essential, obviously, but I think there is a lot of other things that you need to think of, especially in a country response. Yeah, country response, yes, you have to have ventilators. You have to have an oxygen source and reservoir. You have to set up intensive care, whether it's a hospital or field hospital. You have to think of other equipment that is work together, which is infusion pump, cardiac monitors, medication. And very, very important is the PPE for staff protection, because if you lose your staff, you have no soldier to fight. So, you know, weapon alone is not going to be enough. If you go to the next slide, which talk about the manpower. So the manpower is essential, right? So we know we have shortage worldwide in critical care staffing, whether it's in the UK, in US, in Sudan, and Qatar, everywhere, there is a shortage of the staff. Whether they are doctors, nurses, RT. So with a pandemic and epidemic like this, there should be a mechanism to utilize non-critical care clinicians to join the pool and to really have a quick training and induction to let them join the workforce. Same as you do when you have a war, you call for volunteers and you train them how to you know, do the basic stuff, and then you deploy them more than assistants. So that would have to be taught in a countrywide. And it's very important for this ICU staffing and non-critical care and critical care to be proximal to each other. So you expand proximally to improve the utilization of your staff. Don't dispatch them in a different site, because that will just make them ineffective. Moving to the next slide, which I'm going to skip quickly. So if you go to the next slide, please. When you do staffing model, you have to think about patient safety, staff safety. That is a sustainable plan, is a dynamic, and can be deployed in different sites. Moving to the next slide. So in Qatar, we thought about training various doctors from different specialty, internal medicine, surgery. Obviously, anesthesia already have a very good understanding of critical care anyway. They are intensivists, most of them. But the non-intensivists, they get induction course and training. We develop a curriculum, and I think this is what we need to focus to enhance the skills of non-critical care provider, to let them be able to treat these patients. Because if the number comes high, we have to be prepared. Some of them will do hands-on training before they join the battlefield. And I put some example of the model in the next slide. Can you go to the next slide, please? So that's just an example of a model, how you have one doctor overseeing. So this doctor can be different specialties. You can have one ICU doctor covering like 90 patients, for instance, but he has to have the support structure, the intermediate clinician who will support and really zone the patient in different areas. So, and I will talk about this in the next 2 slides. Can we move to the next 2 slides quickly because of the time? Next one, please. Yes, this one. Okay, this is good. So here it, okay, fine. So yeah, that's fine. So nurses is pretty much the same. Target nurses that we targeted was the PACU OR nurses, internal medicine floor nurses. It's very important also to have nurse educator to help in training them. It's very important to learn donning and doffing to make sure they are safe to practice in this environment. And prone position ventilation save lives. This is essential. Very simple, does not need resources that people need to really train to do it. You can do it even before intubation. It improves VQ match. It improves lung recruitment. Then they have hands-on training and joining the battlefield. Next slide is another model where people utilize, which is say, okay, let's have a different group, intubation team, prone position team, regular management team, and then a team really focused on multi-organ support. So this is all our different models. None of them is superior to another, but it's there, and that need to be discussed when the team in Sudan planning to deploy that for their ICU. Next slide. Next slide just summarize the response. Yeah. Now we have a few cases. So it's very important to early on identify the zone where the infection contain these zones as quickly as possible, and then thinking of a mobile ICU deployment. And this is important to start to train and prepare your workforce who can join the battlefield, yeah? From a different ICU provider and non-ICU provider, mix them up, make the skill, and they can go and fight if you put them in a safe place so they can really give you best resources. It's important to include intensive care team in the planning because they are the people who's going to lead the battle. You cannot just push them off guard to fight. They need to be prepared to do their best. So I go to the next slide and just summarize up. This is really a national threat. Yeah, it's not just a job of Ministry of Health. It's the Ministry of Defense, Interior, Civil Defense, Trading, and so many. And most important is the people, education of the public, and you know, hand hygiene and social distances is important to prevent the spread. It's very important to prevent it from spreading rather than just treat a massive casualty. So going forward to the next slide, which is it's number one step we would recommend actually to do a national-wide critical care network over all the country to assess the resources and to really work together, because you cannot treat this in isolation. You know, this has to be a national response for all critical care providers in the country. Come together, assess equipment, manpower, capability, potential recruit, work as a group, and deploy your team in the area that is needed the most. Yeah, you have to align your manpower by the training of non-ICU clinicians as well, and put the model that work for Sudan based on the resources that's available. Ventilation management, pro-ventilation PPE is the three things that people need to learn really. Hemodynamic optimization, when they go to multi-organ support, this need to be treated in a special area. But if they have single organ failure, they need to be, you know, the team should be able to treat these patients. Protocol care based on available country resources. I cannot put ECMO as a tool here because, you know, it's not available. So you have to think what's available in the country and how can you utilize your resources to the maximum best to save people, save lives. You should have an escalation plan based on the phases of the epidemic, and ethical principles have to be discussed in each country. So take home message in the next slide, pretty summarizing what I just said, and all my colleagues before me described. Can you go to the next slide? COVID is a new virus. It's a very contagious with evolving facts. 50% ICU mortality at the top ICUs. Talking about UK, Italy, US, China, 50% mortality. That's pretty high. PPE ventilation management and prone position ventilation training is required to face the respiratory complication of the COVID-19. This is not going to help with the cytokine storm. You need to be prepared, and to multi-organ support need to be thought of. There is a need to establish National Critical Care Network, ASEIT, to cope with this pandemic. This should be done in every single country. UK have a very good network, but other countries don't. Italy, finally, they mobilized their network, but initially they did not mobilize it early, and so on. So this network is the key for the fight. COVID-19 is a national threat, require countrywide resources mobilization. Prevention is essential, and I end my presentation with the last slide. if you go to the next slide, which is that we have to pray. اللهم إنا نعوذ بك من جهد البلاء ودرك الشقاء وسوء القضاء وشماتة الأعداء. اللهم إنا نعوذ بك من زوال نعمتك وتحول عافيتك وفجأة نقمتك وجميع سخطك. جزاكم الله خير.
شكرا جزيلا سهيل دكتور إبراهيم، وكل عام وأنتم بخير بذكرى أبريل. شكرا سهيل يعني التنبيه بذلك. ودكتور إبراهيم, very important point, the soldiers and the protections of the soldiers. This is an important issue that we may need to come back to. Shukran jazilan, and thank you for all the speakers coming today, despite all of the what's going back home and what you are doing and working on. We hope for the next I would say 30 minutes or more that Shaza and Mohammed Jamal will take us through the questions and answers. We hope our colleague back home can ask all questions they would like for the panel. This series of webinars is mainly for bringing us together, supporting each other, and learning from each other. So, Shaza, Mohammed, hand over to you.
Okay. Yeah.
Okay. Assalamu alaikum. I'm Shada Taha. I would like to direct the first question to Dr. AbuObida. Hello, can you hear me, Dr. AbuObida? Okay, so it doesn't seem that Dr. AbuObida is with us on the panel. So I would like to direct the first question to Dr. Suhail Ahmed, please. So the first question is from Dr. Mawahib. How can Sudan handle the situation with very limited resources for ICU?
Well, I think we have to get our priorities right. So when we are under-resourced, you try to use the resources to prevent the masses from needing advanced support. So the way we're playing it now in terms of education, social distancing, hand hygiene, sneezing at your elbow. I think this is the right path. Then the second step, which will come if this does not contain the virus, is of course having dedicated, well-equipped centers, trained personnel, as Dr. Ibrahim was alluding to, which can deal with these advanced cases, and stressing on what we have got and simple maneuvers that make a big difference, such as teaching the staff how to prone the patient and how to look after the prone patient, instead of going after getting expensive equipment which no one will know how to deal with, such as ECMO and stuff like that.
Thank you. The next question is from Dr. Lamia Al-Hassan. She's mentioned that this curve is seen almost identically in all countries with the confirmed COVID cases. Is this something that you've also observed or witnessed?
Sorry, Shaza, is this directed to me or to Ibrahim?
She did direct it to you, but maybe we can later on ask Dr. Husam to comment on this. Thank you very much, Dr. Suhail, for answering the questions. I will now move on to Dr. AbuObida Hamor, please.
Can you hear me?
Yes, we can.
So
the first question was from Dr. Ahmed Saadeddin. He had a few questions. His first question was, so you started anti-COVID in your patient, although his test was still pending.
Yes, the internist who saw the patient in ER made a clinical diagnosis of COVID based on the clinical presentation and the lymphopenia and the minor changes on the X-ray, and he decided to start the patient on that combination. And the next question also is about sending the patient home with an abnormal X-ray. The patient was clinically stable, and the physician who saw this patient made the judgment that the patient was could be managed at home, and he gave the patient clear, guidance to return to ER if he developed breathlessness, and that is exactly what happened. 2 days later, the patient came back because of worsening breathlessness. But he made the judgment that he was stable enough to be managed at home, at least initially, because the course could not be predicted. He could have equally improved and not come back. So that is a reasonable strategy in a patient who's stable and not hypoxemic, doesn't have any signs of severe pneumonia, is not requiring oxygen supplementation. So that was a judgment call.
He also went on to ask about lymphopenia.
Yes, the lymphopenia, as I mentioned in my presentation, is a cardinal feature of COVID-19 disease. Over 80% of patients are likely to have lymphopenia, and that is almost an invariable feature. I think the questioner asked whether the lymphopenia could also be caused by some of the treatments. I mean, in the patient, if the question was related to the case I presented, the patient did have lymphopenia even before he was started on any medication. So it was, in this case, was not related to treatment. Of course, there are some medications that may cause lymphopenia, such as immunosuppressive therapies and so on. But this patient was not on any immunosuppressive therapies at the time of presentation. So this was part of the COVID-19 disease, and it is a very important clinical clue to the diagnosis of this condition. The next question from the I have here on my list is the use of plasma of the recovered patient, the use of convalescent plasma. There are anecdotal reports in the literature showing that this may be beneficial, but to date there are no controlled studies. Here in Canada, could somebody mute their phone, please? There is a lot of noise in the background. I can't even hear myself. In Canada, there is a large multi-center study looking at the utility of convalescent plasma, and I'm sure there are similar studies elsewhere that are looking precisely at this question to see whether convalescent plasma can be used in this setting. So obviously it's not a new treatment, and this is a time-honored, old-fashioned therapy in infectious disease management to use convalescent plasma, and that is the basis of this of these studies. But as yet, there's no data from multi-center or randomized studies to recommend it on a wide scale. So for now, we have to use it only as part of studies. And this applies to all the other medication, whether it's chloroquine or whether it is anti-IL-6 like tocilizumab or other agents. There are really no controlled data to support the use of any of these experimental agents. And here in Canada, our position is that these experimental drugs should only be used in the setting of clinical trials. That is the standard of care that we have in all Canadian provinces right now. Let me see if I've got. There's a question about heparin. This is gaining momentum. The pathogenesis of this disease, as explained by my colleagues, involves microemboli or microthrombosis in the lungs, and there is mounting evidence to support the recommendation of anticoagulation. I know there is a document that has come out in the NHS supporting the use of anticoagulants. And similar documents have come out from Mount Sinai hospitals and other jurisdictions supporting the use of therapeutic doses of heparin, either infusion or enoxaparin or low molecular weight heparin in this setting. And there are some studies that show benefit.
Thank you. So that answers the questions for Dr. Iman Al-Zubair as well as Dr. Ala Al-Malik. We'll move on to Dr. Ishraq's question about being from a black or minority ethnic background not a feature as is widely propagated in the media. This question has also been asked by Dr. Ahmed.
I am not sure if I know the answer to that question, whether this is just it's a chance, or whether there is some other reason for that. I know that there has been a call for an inquiry and an investigation in the UK to look at why all the casualties on the front line have been international or immigrant positions, but we would all await with interest if there is any scientific reason for that, or if there is any, or this is just a mere chance. I don't know. I'd be speculating if I try to answer that question.
May I just ask to if Husam would like to make any comment on this area, Shaza, please.
Sorry, in which area?
The question that Shaza have just asked about the risk factors from what you have seen, the sort of black, Asian, and minor ethnicity.
Yes, I mean there is this is a hot issue here in the United Kingdom. People are looking at the data now to see if that's really a significant factor of the other issues or the other factors in addition to the BAM question. So we don't have the answer yet, but everybody now is looking into that. I know that, for example, in my profs they are investigating that, and they're looking at all the cases and looking at to see if there are any confounding factors or this is a true risk factor. So we don't know the answer to that yet.
Thank you. So this question is directed back to Dr. AbuObida. Dr. Dr. Hiba has asked, why is hypertension considered a serious risk for developing severe disease?
Thank you. This has been obviously observed in the Chinese data that patients with comorbidities, including hypertension, have a poor outcome. It's not entirely clear at this stage whether it's hypertension per se or uncontrolled hypertension. It may be lack of control hypertension. But also there is additional question of whether I think we need more data or sub-analysis of these studies to see was it hypertension or was it its treatment? And I tried to find an answer to that question before one of my previous talks, and I couldn't from the literature because there is this connection with the ACE2 receptor in the alveoli, and it's postulated that patients who are on ACE inhibitors may upregulate their receptors and hence become more prone to severe disease. This is not proven at a clinical level. It's only a hypothesis that being on an ACE inhibitor may upregulate the receptors and hence make the person more susceptible to a higher viral load or higher viremia or viral infection in the lung. So it's not entirely, this area is not entirely clear and requires further analysis as to see whether it's actually hypertension itself or its treatment or lack of control are the culprits, or are what is making people susceptible to poorer outcome or to fatalities.
Thank you. Dr. Iman has asked, how is Canada monitoring the side effects of chloroquine? Are there any cases of significance that you may note and share with us, please?
As I mentioned earlier, in Canada, chloroquine or hydroxychloroquine are not recommended as standard therapy for COVID disease. They're only used as part of clinical trials. That is not to say that there are some people who are prescribing them, off their own bat, so to speak. And one of the reasons that, in fact, the Royal College issued all the Royal Colleges, the Royal College of Physicians, Nursing, Pharmacists, issued a very stern warning about the use of chloroquine and hydroxychloroquine in COVID because there's just simply no data. In fact, today I saw a study pre-publication in the New England Journal of Medicine that is going to be published showing that chloroquine or hydroxychloroquine actually resulted in more people ending up on a ventilator. And this study is from China. So it's not a panacea, as Mr. Trump would like the world to believe. The data for chloroquine is very, very controversial, and more we're seeing more data showing a negative effect of chloroquine. Furthermore, chloroquine or hydroxychloroquine are not without their side effects. They may result in QT prolongation, especially in combination with azithromycin. They may result in arrhythmias and cause significant morbidity. So they are not, the safest drugs in the world. Their use should be restricted to these clinical trials. Whether we are monitoring this in Canada, of course, this is monitored as part of the clinical trial data. This is one of the reasons to restrict the use of these drugs within clinical trials so that side effects can be closely monitored in a clinical trial setting where there's a rigorous scientific scrutiny of all side effects and so on, and that's why they're restricted to clinical trials. I hope that answers the question.
Thank you very much for answering all the questions, Dr. AbuObida. We'll now be moving to Dr. Husam Osman.
Okay.
Dr. Husam Osman, just the question earlier about the COVID graph that we mentioned to Dr. Suhail. Have you noticed the same pattern with your experience in other countries as well?
Sorry, I can't remember the graph. That is bad, sorry.
There was a question from Dr. Iman about the COVID graph pattern, so the prevalence of cases. Is it similar to all countries, or is it specific to basically your local country?
No, it is. It is. The pattern of the epidemic is the same in each country. Once it gets hold of the country and you have local spread, then it will take the same pattern, which you will go an upward curve, and then it depends upon the response of the country how quickly they can flatten the curve, but the pattern is the same.
Thank you. Dr. Ahmed Saadeddin has asked a few questions. He'd asked, can the COVID coexist with H1N1 or MERS-CoV?
As I said in my last slide, we don't know whether this virus is going to be a seasonal virus. It's going to be all year around, or so. We don't know because it's a new virus. If it becomes like other respiratory virus, they do coexist during the winter. Of course, we get lots of influenza and RSV, for example, and so on, circulating in the community at the same time. We don't know what virus. This is a new virus. Most of the cases now we are seeing they are not infected by other viruses, but there is lack of data because not everybody is tested for every other respiratory viruses. But we don't know actually the answer to that because, as I said, it's only 3 months in the age of this virus, so it's difficult to answer that question right now.
Dr. Fadil has also asked a related question about the yellow fever vaccine. Can it also be useful against SARS-CoV-2?
I don't know. I mean, I don't know why it should be, because these are completely different viruses. They don't belong to the same family there. So I don't know why he's mentioned that. And then the yellow fever vaccines, of course, you can't use it for mass vaccination because it got its own problems anyhow. So now the yellow fever vaccine is restricted to people who are traveling to endemic areas. It's very difficult. I think it's going to be very difficult to use it for mass vaccination. But I don't think it will work because they're completely different viruses. So I don't think it will work.
Thank you. He has also asked, how can we explain the low confirmed cases in the meningitis belt in Africa, including Sudan? And what most valuable advice would you give to Sudan?
The question about that belt I don't think we know the answer to that. But my feeling is the virus will get to those areas. It's just having widely yet, and I'm not sure the testing is being done on those areas to find out the true magnitude of this pandemic on that region. So we just have to wait and see whether it's just a true phenomenon or not. The advice is definitely the public health advice should be followed. All the measures that the government is asking for should be implemented. Isolation, social distancing, embargoes, washing of hands, all those things have to be followed because, as you can see from all the presentations today, this is not a joke. This is a very serious illness, and people should really follow the public health advice because if it gets foothold in Sudan, it's going to be very difficult to control with the resources we have.
Thank you. Dr. Catherine Thomas has asked something related as well. Her question was, what will happen in large cities in poor countries if physical distancing and lockdowns cannot be maintained?
Because there is no vaccine yet. Drugs, as everybody mentioned, there is no good drugs. So the only way we can fight this is, as I said, follow the public health advice. Try to isolate people, isolate patients, isolate people, washing hands, cleanliness, and so on. That's the only way we can. This is the only tools we have at our hand currently. If the drugs prove useful, and I doubt that anyhow, if we have good drugs, then yes, we could use those. If we have a vaccine, then yes, but I don't think we have those in the next 6 months or something or so. So I think the public health measures are the only way we can move forward and fight this epidemic.
Absolutely. Dr. Muhammad Khalifa, as well as Dr. Ishraq Awad, have asked a similar question. It's regarding the herd immunity idea. So is it a gamble, or would it be actually true to follow the herd immunity idea on the basis that the virus will not mutate too much? Or is it actually a very too early for this management strategy, as we don't know much about this virus?
So the question about the herd immunity is, this is a school of thought that says you let the virus spread, so people will become immune, they're going to get herd immunity, and that's how you fight the virus. But as I said in one of my slides, the price is high because more people are going to get sick. They will need treatment, ICU, and so on. So the price is going to be high. But there is a school of thought which says, yes, you let the virus, especially among young people who are at least at risk of complications, to get infected. So you can build up the herd immunity and then protect other people in the community. But the price could be very high, and that's why most of the countries are implementing harsher measures of isolation and lockdown and so on.
Thank you. Dr. Lamia Al-Hassan has asked, despite lockdown measures, the curve has not flattened and cases are still peaking. Is there a specific reason for this?
Because the issue which I mentioned is, first of all, in the United Kingdom, are we late to implement the measures of lockdown and so on? Are we late that a lot of people now are infected, especially asymptomatically or very mild symptoms, and they are spreading the infection? And I think that's what's happening. I think there are a lot of people here who are mildly infected or asymptomatically infected, and they just spreading the virus. And I think that's why that's happening. And that, as I said, could be because the UK was very late to implement the public health measures, which needed to be done early on.
Thank you. Dr. Tariq Abdullah has asked, why has the number of those recovered in the UK relatively small and far lower than European countries? Is it because we are just under-reporting, or does it reflect advances in treatment in other countries?
I think there is an element of under-reporting of the recovered people. I think people in England here, they are merely interested in the number of infected and the numbers who are sick and so on. So there is under-reporting. And I think also if you look at the care, it started only from mid-March. So people take a while to recover completely from this, especially people who end up in ITU and so on. So it takes a while. So to get the data properly, it will take time to get the proper data about the people who recover. But there is an element of under-reporting also, definitely.
He has also asked, is hydroxychloroquine and azithromycin used in the UK?
It is used in trials only. Just like Dr. Hamor mentioned, they are only used here in the United Kingdom in trials. So there is a big trial now, multi-center trial in the United Kingdom, which looks at hydroxychloroquine, looking at Calitra, looking at hydrocortisone. I think it's four arms or 5 arms, I can't remember. And they are just they're looking into that. So we just have to wait and see what the outcome of those trials is.
Okay. Dr. Ala Al-Malik has asked about a German study that's been published in the news recently about high antibody titer in non-infective healthy carriers. Would you be able to comment on that?
Yes. I mean, this is what I suspect, as I said, happening, that I think there are a lot of people in the community who are, I suspect, have been infected, but they have a very mild infection or asymptomatic infection. The problem we're having here is that we don't have a good serological test yet to do that sort of work. But there is a study, I think, which is done in the blood transfusion center in Oxford, which is going to be published in the next few days. And it says that they looked at the blood donors, and I think they found maybe about 18% of people who are antibody positive. But I haven't seen the study in details, but I think they say 18%, but how good the assays they use and so on, I can't comment on that. But I think they found about up to 20% of people or blood donors are seropositive.
Thank you very much, Dr. Husam, for answering all the questions. We'll now move the question panel to Dr. Ibrahim Hassan, please.
Yes.
Thank you. Our first question is from Dr. Ahmed Saadeddin about the role of steroids in ICU management of COVID patients.
Very good question. I think, again, it's an evolving science. We are learning, and there is a lot of randomized trial that's running at the moment. The recommendation for now, until we have more data, is to really use it in the right setup. And the right setup is really when you get cytokine storm. That will be applied not only for steroid, but also for immunomodulator to decrease the inflammation. Other than that, there is really no data. It's delay the presence of the virus in the body and can lead to another complication. So the recommendation would be really in this group of patients that have an inflammatory storm to try to control the inflammation.
Thank you. He also asked about do not resuscitate directives with patients with high risk of mortality. How do you find that in your practice?
It's an ethical dilemma. We have a team working on the ethical principle during the pandemic and epidemic. It's important to associate that with your phase of the epidemic, because in the beginning of the epidemic, when you have a lot of resources, you really have to treat people, ethically appropriate. But again, that has to be clarified. If you have someone who's 90-year-old who's bedridden, would you do resuscitation for this patient? That's a big challenge. But if it comes to a 40-year-old who is very sick with multi-organ support, would you treat or you will not treat? This is all dependent on the resources and the availability of the equipment. If you run out of everything, what are you going to do? So it varies from a country to a country based on the resources, and more importantly, in the phase of the epidemic. If it's in the peak and you exceeded your capacity, you have to target your treatment to the people who will benefit the most. It's a bit difficult, but this is exactly what happened in a war. When you are in a war zone and you have a lot of casualties, you will really look for the people that you can save. Some you will not be able to save. I hope we never reach this stage, inshallah. But this has to be really assessed in this context. We cannot generalize. It has to be assessed in the phase of the epidemic and whether you exceeded your capacity or not.
Thank you. Dr. Rawi Ahmed has asked, any experience in proning non-ventilated patients? Can this delay ventilation or help reducing oxygen requirements?
Absolutely, yes. In our center, we've done that for many, actually, for a long time. And now the data and evidence is worldwide. Many top centers utilizing prone ventilation strategy way ahead of intubation, and many of these patients will improve without the requirement of mechanical ventilation. So this is something, if something you need to train is a prone position ventilation. This is really save lives. I think for every ICU, this is something we have to utilize more and more. In Qatar, we have a very big team who are doing training everywhere on prone position ventilation, and it's very, very effective. Decrease the need for rescue therapies remarkably, whether it's intubation or ECMO and others. So something that we will definitely echo or will recommend highly, prone position.
Thank you. This is very vital advice. Thank you very much. Dr. Bahauddin Osman has asked about the role of ECMO in the treatment of COVID-19 critical patients.
It's my area of expertise. So I'm the chair, past chair actually, for ECMO in Asia and Africa for last year. And it's the thing that I love the most. It requires a lot of resources. ECMO play a very important role in COVID, whether it's a myocarditis and cytokine storm or severe respiratory failure who is not responsive to mechanical ventilation. The reason I did not mention ECMO because I know it doesn't exist in Sudan yet. The first case was done by our team. I was there and we retrieved this patient to Qatar. So I knew the technology is not available. That's why I didn't want to touch about it. It requires a lot of resources. And again, you know, it's all depends on the phase of the pandemic and epidemic, whether you can, if you have a choice, you have two clinicians, and you have two patients, one who requires just simple intubation and one who need ECMO, or 5 who need intubation with one team, the same team will treat only one patient in ECMO. Which way you will go? So it depends on your resources, but should ECMO be included in the management? Absolutely yes, because it's actually very effective and it can treat so many patients who will fail in mechanical ventilation, cytokine storm, who otherwise will die. But again, this will come to your ethical principle. Did you increase your capacity? Do you have resources? Do you have a trained team? Alhamdulillah, we have it here in Qatar. I hope in Sudan it will be available. In UK, I'm sure they have it. But it's something that's very powerful, but it needs a lot of resources.
Thank you. Our last question is about ventilator settings by Dr. MOB. He's mentioned that high pressure is not usually a good plan. Do you mean high MAP or high PIP or high PEEP? And is volume a guarantee as an option in adults?
When we talk about high pressure, he seems like an intensivist or have a good intensive care knowledge. We apply to a PEEP number 1 and then the driving pressure. The pressure, not the MIP. We don't, very few people now look to the mean airway pressure. We look to the driving pressure and to the PEEP. Some of the lung, in usual ARDS, you assist recruitability, you give them a higher PEEP, you put them in ABRB mode or a high driving pressure mode. That will help these lungs. Other group of patients, it will not, especially if their problem is not in the lung parenchyma. It's a microthrombi, it's a vasculopathy, it's a other related issues that worse the VQ mismatch. Higher pressure is not going to help, but only can cause complication. So, and I've seen another question talking about can this lead to complication? Absolutely. You know, if you ventilate people in the wrong way with not tailored to their need, it can cause a lot of problems and can kill people. And we hear this in the news and the report that mechanical ventilation can kill. Yes, it can kill if you do it wrongly. That's why you need to train people, and that's why there is a specialty called intensive care that people go through it and they understand how to ventilate patients.
Thank you very much, Dr. Ibrahim, for answering these questions. I will now hand the microphone to Dr. Mohammed Jamal to address the remaining questions. Thank you very much.
Thank you.
Okay, thanks, Shaza. The next 3 questions will be to Dr. Magda. Dr. Magda, are you available? Okay, while I wait for Dr. Magda, there's a question maybe to Dr. Ibrahim, if you're still around. So there's a question from Dr. Hala AbuObida, who's an intensive care consultant. Pragmatically, how can we help Sudan now by getting the critical care network up and running?
You know, this is the question in the heart of the problem. And to me, I run the critical care network in Qatar for a long time, and it takes a lot of effort, and it's something that needs to be, you know, Sudan is much bigger obviously than Qatar. There is so many different hospitals. I think that something has to be started ASAP by the Ministry of Health or the leaders of critical care in Qatar. They need to come together and analyze all the ICU within the country, you know, get all the directors, even do a Zoom meeting, put a strategy. What is the manpower that's available in the whole country for critical care? Yes. What is the capability of training, or doing online training of people within critical care or non-critical care? what's the equipment? We need to have the list of all the equipment in the country and where to resources. You will be surprised. Some of the hospitals will have ventilators that they are not using and other are overwhelmed. So this distribution of the resources within the country is essential, because you will be very surprised of number of equipment or medical staff who are available and they are not participating, and other areas is really overwhelmed. So this is the time to pull this together. And to pull it, I think the Ministry of Health have to initiate this. They have to appoint a lead, and the lead needs to bring people together and streamline the workforce. Otherwise, you will not be able to fight. You have to think about it as an army. You are deploying an army. Train your people in different grades. You can deploy even medical student and nursing student to this workforce. Train them quickly. Do induction. I'm happy to assist. If anyone asks me for help, I will be delighted to help. It's something. It just needs to be initiated. I cannot initiate it from here.
Hello.
Yes, can you hear me?
Yes, we can, yeah.
Hello? Okay, sorry. Just so it's a question in the heart of the problem, because work is the team who's gonna fight this when it comes to the hospital. If it doesn't come, it's all the preventive measure, but the IC team will get the heat.
Okay, thanks very much for your answer. Dr. Magda, are you available? Yeah.
Yes.
Okay, so there's a couple of questions for you. First question is from Dr. Hisham Al-Kidir. How can Sudan bring pressure on the international community to relax monetary transactions to help with funding the local response?
I really don't know. I think there has been a lot of pressure from people to the government to just ease the means of receiving money from abroad. I don't know really what is the problem, and I'm sorry. I think they declared that Bank of Khartoum is ready to accept. People can transfer through Bank of Khartoum, but I don't think it is happening.
Okay. So another question is from Dr. Sarah about the role of WHO in supporting low resources setting PPE.
There are a lot of donations coming in from UNICEF. I think UNICEF now is in charge of the emergency funds, and then there are very important local efforts. The group of lady doctors who were able to, find the material, and actually they are trying to manufacture it in Sudan. There are a lot of people in diaspora sending shipping, and I think some of these things are arriving or have already been received in Sudan. But the demand is high, and I think there are so many efforts to get more of these protective equipment.
Okay. Thank you very much. Obviously, that's a question that concerns a lot of healthcare workers in Sudan regarding PPE. I'm just moving to Dr. Husam next. Dr. Husam, are you available?
Yes.
Yeah, okay. So I think this question has been asked in a different way earlier, but so the question is from Dr. Husam. Do you agree that the low number of cases in Sudan could be possibly due to low number of tested cases?
Yes, that could be. That could be a factor, because I know there is a very small number of tests that have been going on in Khartoum right now, and we don't know what's happening in other parts of the country. There is no testing at all. So yes, that's why I'm saying the people shouldn't just believe that this belt zone and the protection and so on. I don't think that's the case. I think people should be very should be clear that this is not should be very clear that this is not the case, and look for cases and be very open-minded about what's going on there.
Right, thanks so much. So the next question is from Dr. Rashid Mekki. He's asking about BCG vaccination, which is obviously a good number of people are vaccinated in Sudan. Any comments on that?
Yes, also that's one of the series that have been mentioned, that there is a link between people who are, one of the explanations that has been given about that zone, because people are mostly receive BCG, and BCG could have providing some sort of immunity, or the immune system is primed to deal with anything. I don't think there is enough evidence yet to say that. It's just an observation, but I think we have to wait and see. I don't think there is enough evidence to support that yet.
Okay. The next question is from Dr. Husam Al-Kidder. He's asking about children and why the clinical presentation is generally mild. If you have any thoughts about that.
We don't know. We don't know the answer to that. But this is something we have been noticed. Not just children, even young adults. The infection usually is mild or asymptomatic. But in children, it is more noticeable that there is very little going on among children. We don't know that. We don't know the answer to that. I don't know the answer. Maybe some of the other speakers could have an explanation. But it has to be something to do with the immune system, of course. Whether that the immune system in children is not mature enough to generate the cytokine storm which everybody is talking about, that could be a factor. That's my own interpretation. So, I think if none of the speakers have got any other explanation.
Okay. For the sake of time, there's a lot of questions, so I'm just going to maybe pick another 3-4 questions, and then we'll conclude. There's a question from someone which has came in as A. This is a question for maybe Dr. AbuObida.
Can you hear me?
Yeah, Dr. Hamor, are you around? Yeah.
Yeah.
So the question is, this is someone who's saying that as someone who's not from the medical field, I'm worried about how long this pandemic would last and how to keep safe mentally. I think as a clinician that you have dealt with a good number of cases at this stage, what's your feeling around this?
This is a difficult question to answer because it very much depends on how we respond to the pandemic. As Dr. Anthony Fauci often answers this question, if we stick with by the social distancing and community measures that have been recommended, then we could be looking at months rather than years of pandemic. But it's difficult to know for certain because it all depends on human behavior and how people respond. And we can see that how that is different from one country to another. The other factor that will determine the duration of this pandemic is obviously the discovery of an effective vaccine. And we know that is not going to be possible for at least a year. So because if there is an effective vaccine, then that may halt the spread of the virus. But we don't have that yet, and we're unlikely to have that this side of 2021. So how people can stay and maintain their sanity during this is by just really sticking with family, maintaining a healthy lifestyle, to make sure that people's immunity is good, a healthy diet, exercise, good number of hours of sleep, minimum of 6 hours of sleep, having enough, drinking enough water or fluids in general, avoiding cigarette smoking and alcohol, and just maintaining good health and resorting to things that one can enjoy doing in their spare time, such as exercise or reading or connecting with family and friends and so on. So that is all what we can do. But in terms of predictions, they're difficult to make, especially when they're about the future.
Thanks very much. I hope in the next few forums we might be able to get someone as well who's a psychiatrist or a psychologist to help us answer such questions as well. So I'm just moving to Dr. Ibrahim. Dr. Ibrahim?
Yes.
Yeah. Okay. So I think there's about 3 or 4 questions all talking about non-invasive ventilation and the best time to start mechanical ventilation. So there's a question from Dr. Najmuddin about what's the best time to start mechanical ventilation, and a question from Dr. Lai Idris about whether we could use CPAP and high flow nasal oxygen as a holding measure to spare the ICU capacity.
This is obviously very, very good questions, and the recommendation keep changing, and it's mostly dependent on the resources that available in the country, in the hospital. So briefly, non-invasive ventilation, it does improve oxygenation. The risk of NIV in severe pneumonia is most patients who comes into the intensive care with severe pneumonia, NIV does not really prevent them from intubation. So it just delay intubation and increase risk of healthcare professional of infection. CPAP and NIV is very good in pulmonary edema and other very mild cases of pneumonia. They can be tolerated. So in our system at the moment, again, there is no really clear guidelines. It's depending on your resources and the phase of the epidemic. So in our system at the moment, we said, we don't want to take any risk of a healthcare provider because we have a limited staff, and we're still early in the pandemic. So we took approaches early intubation. We will not spend time in NIV. We will go from flow, nasal cannulas to intubation. Other countries who got hit hard, they changed their protocol, especially in Italy and England. They said, you know what, this number is massive, so we cannot really intubate everybody because this is also have a risk. So they start to study what is the best approach. So NIV in negative pressure room or area that can be safe for the healthcare provider to provide this treatment is reasonable. High flow nasal cannula have a problem because it consumes a lot of oxygen. And if you use it in so many patients, you can consume your oxygen resources in the hospital. And we already have cases of a near shutdown of the oxygen resource in some of the hospitals in the chest where they just ran out of oxygen. So it carries this burden because it works with a very high flow, 60 liters per minute and others. So it's a pretty high flow. So to summarize, the answer for that would be, depending on your resources, can you use NIV? Absolutely, you can, but you have to be careful with your staff and do not delay intubation. So if they don't improve quickly, move to the intubation. Nasal cannula probably can be used, but not in big numbers because it will affect the oxygen reservoir in the hospital. So that's about that question. Actually, I answered both of the questions at the same time because it's NIV and high flow nasal cannula.
Yeah, that's very helpful. I think we're just running over time, so there's a last question. And Sarah, I'll direct this question to you because you'll be best to answer this, and also because you'll be taken over to conclude. Khalid Nasr is asking, how can this forum help setting hospitals ready in Sudan?
Okay, thank you for the question. I think this forum is one of the tools that we can help. There's a lot of effort by Sudanese inside Sudan, and we have to salute them for the many tremendous work they have done on the ground and protocols, and the effort of the Ministry of Health and the specialist sort of groups, as well as the diaspora, not only by funding, but as well logistics, ideas, debate, and this forum is for this purpose. So we'll try to have another session in about 2 weeks with different themes. We would hope that our colleagues from Sudan will join to share the protocols, the ideas, and what they would like us to help with. This was just like a tester so that we all meet. We have to remember as well that the support is for all Sudanese diaspora all over the world. We are all facing this problem. Before, when we talk about cholera outbreak, at that time we were not facing the same pandemic. Now we are all, on the same shoes, whatever the facilities. I would like to thank the ASEIT team for their effort and patience, and the distinguished speakers who participated today with us, for all of you who have attended, and for the valuable questions and the answers, and for my colleague Shaza and Muhammad. And we hope we will arrange another webinar in about 2 weeks' time that will be led by Mr. Ala Al-Malik from SDU Canada. So SDU, Australia and New Zealand. So thank you, everybody, and stay safe. And the last message, as Dr. AbuObida said, prevention is the main step for dealing with this pandemic. Thank you very much.